I want to give a big welcome to everyone who's joining us in our audience. As I mentioned previously, go ahead and introduce yourself in the chat. Tell us where you're joining from to make sure you're in the right place. This is the Healthcare and AI webinar today, sponsored by Cliexa. Big thanks to Cliexa for sponsoring this panel today. We have some wonderful guests, and we have some people visiting us in our audience from Spain. Very exciting. Thanks for chiming in and thanks for being here today. I'm Katie Richardson. I am a pediatrician, and I am an entrepreneur, a mom, and a lover of healthcare innovation. Super happy to be here today to be the MC of this great panel. And I'm going to let the panelists go ahead and introduce themselves. And what we want to know is a little bit about you, where you're from, and how you're connected to cliexa. So we'll go ahead and start with Jeremy, because he's just to my right on my screen here today.
Thanks, Katie. Good morning. My name is Jeremy Pira. Although I've spent 25 years working in health IT, I am the only non-physician on the panel. So Katie has promised that she's going to go easy on me. I began my career at Allina Health in Minneapolis and spent, after a few years at Allina, spent about 12 years consulting on rev cycle projects and EHR implementations in hospitals, in clinics, home care settings, hospice programs, and labs. I created an interoperability company in 2014 that we sold to Lineate in 2021, and early this year joined Lucem Health. Lucem is a company that Mayo Clinic and a few other investors launched in middle of 2021. And our mission is to revolutionize care delivery through the practical application of clinical AI. Our cloud platform enables our model development partners like cliexa to deploy, commercialize, and continuously improve their AI models. So thank you for having me.
Love it. Welcome. I have to tell you, Jeremy, my sister actually works for Allina Health in the Lakeville area. So I'm familiar with them in Minnesota. So welcome. Thanks for joining us. So next I have Dr. Arlen Myers. Arlen, go ahead and tell us about yourself and how you're connected to cliexa.
Yeah, thanks for inviting me, and it's a pleasure to be on the panel. Mehmet and I go way back several years, and actually I was part of the initial advisory team when he created the company. In the spirit of disclosure, I'm an equity shareholder in the company, and at one point was the chief medical officer. I'm now the president and CEO of the Society of Physician Entrepreneurs.
Wonderful. Thanks for being here today, Arlen. You're selling yourself a little bit short, and I know we have your LinkedIn profile and other things that for all of our panelists that are being put into the chat. So I encourage all of you in the audience to check out, again, all of our amazing panelists. I have to say though, Arlen, I think I might have beat you for initial advisor to cliexa because I worked with them when they first started the company, but
I stand corrected. I'll have to put that on, have to add that to my failure resume.
No way, no way. All right. Welcome again to our audience of attendees that are joining us. We're just getting to introduce our panelists here today. If you're in our audience, go ahead and introduce yourself in the chat and let us know where you're joining from. I'm going to move on to Dr. Erin. Please tell us a little bit about yourself and where you're joining us from and how you are connected with cliexa.
Good morning. Thank you. I'm honored to be a part of this panel. I feel like a baby doctor in the world getting into this field. And how we know Mehmet and cliexa, we're actually looking for tech partners right now to help us with innovation and really direction on where we're going with our new startup. So I'm a board certified pediatrician, adult psychiatrist, and child psychiatrist. specializing in eating disorder care. I've been working with eating disorder patients for almost 10 years, most recently at the highest level of care in a facility that has inpatient residential, partial hospitalization, intensive outpatient treatment. And for 10 months, I was at the only eating disorder ICU in the country as their sole psychiatrist. So being at these higher levels of care, I've seen firsthand what happens when treatment is not available and readily accessible for patients. And so we started Very Health, Virtual Eating Recovery for You, as a way to bridge that gap and offer psychiatry, therapy, and dietary services to outpatient individuals ages 10 and up with primary eating disorders. So not just anorexia and bulimia that most people are familiar with, but avoidant restrictive food intake disorder, binge eating disorder, unspecified eating disorders, and really trying to create that gold standard of care with a team model in the outpatient setting.
Wow, that is so cool, Erin. As I mentioned, I'm a pediatrician too, and I know that this type of care is very needed. So very cool that you have taken this virtual and are doing all kinds of cool things at Very Health. I'm excited to learn more about it. That's awesome.
Thank you. We're very excited too. And maybe
yes.
overwhelmed. We feel like chickens with our heads cut off most of the time.
I believe it. I totally believe it. Well, this is excited to have you here. And we'll move on to our last panelist, Dr. Eric Eskioglu. Did I pronounce that correctly?
Yeah, you
got it. Did I get
right.
Close?
Yeah, you're good, Katie. Thank you.
Okay.
Hey, Eric Eskioglu, Executive Vice President, Chief Medical Officer at Novant Health. We are a 17 acute care facility, as well as over 750 ambulatory care sites, integrated healthcare delivery system out of the Mid-Atlantic. I've been in this organization for 7 years. I've been in my current role as the Chief Medical Officer for over 4 years. I am by training originally an aerospace engineer. I worked at Boeing for 3 years before going back to medical school. I did my training at Vanderbilt. I am a vascular neurosurgeon trained at Vanderbilt and have been a big AI advocate for about many years now. But the first time I started talking about it, I remember in our health system about 5 years ago, everybody looked at me like I had horns growing on my head. People didn't really understand what I was talking about. They thought it was kind of a fad, but luckily it's really making its way through the entire health system as well as in the US. So happy to be here. Thank you.
Wonderful. Thank you for joining us. I'm excited to hear more about Novant Health and what you all are doing there. It wouldn't be a day without seeing my good friend Mehmet here on our webinar. And so I'm going to allow you a couple of minutes to say hello and speak to our audience and get us kicked off about what made you want to have this webinar.
Absolutely. Thanks, Katie, and thanks, everybody. And thanks, Arlen, for organizing this for us from the beginning. I think everybody knows AI has been like in the horizon for a while now, and there are a lot of myths, I think different understandings from different people. And when you add the healthcare mix to it, it becomes even more complicated in different areas. What I wanted to do really put some people, experts in the area. I'm really honored to have all these folks, and I have known them for a while. And you're right, Katie, I think we started journey with you, and then Arlen has been amazing in the beginning, just like you are as an advisor. And Jeremy, we met through that, and Dr. Eskioglu, we met actually a couple of years back, and I've been following him closely. I'm also a pilot, he was on aerospace engineering. It's an amazing background, and Erin on the eating recovery for the pediatrics area has been an amazing group to meet with. And I said, instead of me only benefiting from these people with their expertise, how they look at AI data specifically, I wanted to share with the audience and give them a chance to ask questions. And thanks for moderating here, Katie. It's lovely to see you, and I couldn't be a better moderator today.
Wonderful. Thank you, Mehmet. I'm super excited as well. Some, like I said, great panelists, and we have some tough questions lined up from them, but we'd also love to hear from our audience. There is the Q&A function enabled on your bottom toolbar, so don't hesitate as we move along to put questions in Q&A, and we will take them as we move through our questions as well. The first thing I want to do, because as you said, AI has been growing, I think, in popularity. So potentially, the statistics that I have here say that the healthcare market, the AI and healthcare market grew 167% from 2019 to 2021. So in 2 years' time. So we know that it is exploding out there. And up to 90% of hospitals now have an AI strategy, and that's up from 37% in 2019. So we know that this is a huge topic. I can tell by the number of attendees we have here today that people are excited to hear more and learn more about AI in healthcare. I would love to, and especially in the clinical setting, I'm going to start with making sure that we're all on the same page as far as the definition of what do we mean when we're talking about AI in healthcare, because I think people throw around terms like AI, machine learning, et cetera. And I'm going to put one definition out there, and I would love for our panelists to respond and add, confirm, do they have it correct, or should we be talking about something else? So AI in healthcare is an umbrella term to describe the application of machine learning algorithms and other cognitive technologies in medical settings. In the simplest sense, AI is when computers and other machines mimic human cognition, are capable of learning, thinking, and making decisions or taking actions. AI in healthcare then is the use of machines to analyze and act on medical data, usually with the goal of predicting and/or improving a particular outcome. I'd love to hear from our panelists. What do you think of that definition? Does that make sense? Are there things that you would add?
I mean, I can start, Katie. I think AI is going to do a lot of repetitive, non-productive work that most of the clinicians, including physicians, nurses, respiratory therapists, pharmacy technicians, do not want to do. And once AI completes those repetitive and automates a lot of those actions, what's going to be left behind is human empathy and judgment, which is we all crave for meaningful work. That's the part of the work that makes us get up early in the morning and go to work. And I think that's where AI is going to shine.
I love it. Great point.
Arlen,
I see.
Yeah,
go ahead.
I would add that, you know, this is the shiny new object. And so almost everything these days has something to do by the author or the proponent as having artificial intelligence. When the reality is that if you ask computer scientists and engineers and people who are experts at artificial intelligence, a lot of it is sophisticated statistics. It's really not artificial intelligence. So my caveat to the audience, and I'm interested in the other panelists who are data scientists, everything that is said to be AI is not AI.
I would agree with that. I think that's why I posed the question about how do we define this?
So maybe Jeremy or Mehmet or one of the other data scientists can chime in.
I'm not smart enough to be a data scientist, but I agree with your comment, Arlen, that essentially algorithms that have rules that are established by a human being generally fall outside the realm of what we call AI. I'm not sure for a patient or for a provider, the distinction makes much of a difference. I think the real question is what Eric pointed out, and that is the objective needs to be removing repetitive tasks that can be done by a machine so that we human beings can do the work that only humans are capable of delivering.
Yeah, I like.
You know,
go ahead.
You don't want me to talk too much today between these people, but I agree with this discussion. I think I want to give like a very quick example here. For most people, really think like a rules engine might be an AI. I'm not an expert. I know a little bit about this myself. However, what I can tell, if you really inform the artificial intelligence, it's basically the process of it with machine learning, telling that this is a car that has one steering wheel and four wheels. It will start learning that pattern and identify what a car is. But if you tell the AI, now tell me if this engine has 5,000 cc, it will just stop right there. So it's like learning about a pattern and then recognizing that pattern in different areas and trying to really figure out, okay, this really looks like with the data you feed me, that's what the outcome is. I think it's a very common mistake, just like Arlen is saying, people really get that a little bit confused. I'm glad you posed the question, and I think that's one thing I wanted to, from my perspective, give a simple explanation for some of the audience here as well.
Love it. Thanks for chiming in.
Yeah, and I think the real issue is, why is the question important? Like, so what? Who cares whether the answer is data or biostatistics or some regression curve or something like that? In my mind, the reason is that clinicians have to assess what they're reading in the AI literature, and they have to understand it's whether they want to incorporate it in an armamentarium that is reliable and valid. So, and we'll get into this conversation, what are the barriers to dissemination and implementation? And one of them has to do with physician understanding of what AI is and can it be trusted to take care of the patient sitting in front of you. So I think that's why it's important.
I would agree with you, which is why I thought I'd start with that question. I think, you know, one of the biggest things from a healthcare provider perspective, I loved what Eric had to say initially, right? There are so many repetitive tasks for all of us, from physician down to, you know, frontline nurses and respiratory therapists, as you mentioned. And there is so much data out there that we deal with on an everyday basis related to our patients. Being able to manage, leverage, and utilize that data, I think, is really important. And trying to really get, again, you know, artificial intelligence and or computers and or machine learning to be able to analyze a lot of that. So we are not spending time doing that. We have to be able to trust it. You're right, Arlen, but allowing the computers to do the things that they can do. So the feeling can come from us, the empathy, as you mentioned, as well as what I would call the solving of diagnostic dilemmas and higher level thinking. Like, that's what we were trained to do, and that's what we want to spend our time doing. So I'm going to jump in with some of our questions here. As I mentioned to our audience, please put any questions you have for our panelists in the Q&A, and we'll take those throughout the next a little bit over an hour we have at this point together. The first question, Eric, I'm going to pose to you. How do you think clinicians can mitigate the risks, as Arlen was talking about, that are associated with using AI models in patient care?
Yeah, I mean, I think first of all, we approach AI from a safety and quality point at Novant Health. So if it makes sense, if it's going to improve the safety and quality of our patients and using an AI tool, then we will go after that tool and try to implement it. One of the things we do is we actually run a parallel process. So when we start a new AI tool, whether it be clinical decision-making or clinical operations, we run a parallel process. And that's the promise I have to the clinicians for 3 months, just so they can see on a shadow process how the AI tools are working versus the current way of or legacy way of doing it. And I can tell you, within most of the time, within 2 to 3 weeks, they come back to us and they want to ditch the old legacy way, because the AI way proves to be much more powerful and much more effective. So I think those are things that alleviate their fears. You know, a couple of things, Katie, that I want to kind of level set here. You know, our medical knowledge, we don't talk about that as much. When my late father trained at UCSF, it was doubling every 50 years. Before the pandemic, it doubled every 72 days. And 2 weeks ago, we found out that it's doubling every 42 days. Just think,
wow.
What we know about medicine is doubling every 42 days. Today is the slowest change of pace you'll ever see in your lifetime in medicine. Every day is going to be a much different game. And there's no way a human mind or intelligence is going to be able to keep up with this. And the sheer amount of data is incredible. We're very data intense. And the data is not, it's not generic data. It's not synthetic data. It's not all homogeneous data. It's all heterogeneous data depending on the patient. So we need a way to be able to decipher that data and get it down to our patients, get it down to our clinicians, almost like a cheat sheet. And I liken it to a fighter jet pilot. When they fly, they get all this data deciphered to them on their, on their cockpit, on the left-hand side of their eye, and they can see what's coming in, what's streaming, what they should pay attention to. I feel like the physicians and nurses of the future are going to be very similar to that, where they're going to be able to see what's important before they even go into the room, before they even take care of the patient. And then I go back to the empathy and critical decision-making. The judgment part is going to come into play. Rather than, you look at us in the clinic. I was thinking about myself in the clinic the other day. We dig through data, trying to find out if it's a new patient, why are they there, and what are their conditions, and what caused them to there. And we dig for every morsel of information. We spend so much time, it's like a hamster on a wheel, going through the EHR, trying to figure out where is the thing that's related to the brain condition I'm seeing the patient for. That could easily be done by machine learning. That could easily be done by predictive analytics. And I think that's where we need to go.
I love it. Great answer. I have a follow-up question to that. Erin, can you give us, or at least I'd love to hear an example, when you talked about these parallel processes, can you give us an example of one recent problem that you were solving, both using AI and running that parallel process, and what that looked like? I want to hear more.
Yeah, of course. So being a vascular neurosurgeon, I've spent my whole career working on stroke patients, and especially on the interventional side, surgical side. And we have seen a lot of delays in treatment, even in the best of times. The door to needle time, what we call getting the clot busting drug to a stroke patient, is about 60 minutes. And if you think about it, every second of a stroke, you lose about 19,000 brain cells. So that's a lot of brain cells. And we teamed up with a visionary company from Israel when we were doing this. And this was 2 years ago. And their system can detect a stroke even before the patient's out of the CT scanner by getting the data from the source of the CT, not the PACS, from the imaging, and being able to tell us there's a patient with a stroke. And what made it even easier is they have an application for that on a smartphone that everybody gets notified at the same time. Everybody gets to know that there's a stroke patient. And it's made a big difference, especially in our rural hospitals, mid-sized hospitals, when we don't have neuroradiologists at nighttime to read these complex images, and they could be missed. And even in our big hospitals, the time lost due to a stat imaging could be 20 minutes. And so this has saved us, in general, this has saved us about 10 minutes on average per patient for stroke time treatment. That equals to about 19 million brain cells per patient. And that has really reduced the severity, the morbidity of our patients. And so we're proud of that. Now, we ran this, it was on the apps phase when we first started, and we were going to run it 2 months parallel process. Within the first day, it picked up a patient that one of our really good neuroradiologists missed on our main campus, and we had to bring the patient to get the treatment, and the patient survived and did really well. So the next day, we had to abandon the old way of doing things, and we had to try to disseminate this system pretty quickly across the entire enterprise. So that was a pretty quick decision.
Yeah, no, I love that example, because there are going to be some cases where that's exactly what you're going to have to do, because patient outcomes and high quality care are going to take precedent over what might be your test of parallel processes. So very cool and very exciting for patients. That's a great example. I'm going to move on to Jeremy. A question for you. How far are we today with implementing AI solutions in clinical care settings from a technology and adoption standpoint? And what challenges do you think the industry is facing today?
Well, in some clinical settings, AI is already used frequently in radiology, in cardiology, even general inpatient care, clinical surveillance software from companies like Sentry7 and Vigilance. They make use of AI models to flag patients with deteriorating conditions. But I think you framed the question well. There's a technology challenge and there's an adoption challenge. So the technology challenge is, the way I think about it, is that AI is a math equation. It's an algorithm. It's tough to just drop a math equation into a clinical workflow. So algorithms by themselves are not solutions, and math doesn't automatically get you to better care. AI models require precise data. You have to calculate. You need that data structured the right way in order to calculate accurate predictions. And like all modern software, to deploy at scale, you'll want to deploy in the cloud for reliability, for access, and for security purposes. So you need the technology platform to be solid and scalable. There's also, I think, two adoption challenges. So adoption challenge number one is that the model output is often a percentage figure or a number, right? You talked about it being a prediction, but that prediction, that percentage likelihood needs to be put into context. It needs to be explained. What does it mean? What other medical information does the provider need to have at hand in order to make sense of that prediction? To some extent, this isn't any different than other UI, UX challenges, right? We now expect beautifully designed applications that essentially require no training. But the AI prediction needs to be matched with other contextual information so the user knows how to act appropriately on that prediction. The other adoption challenge, we've already talked about some, and that is trust. That AI models are often black boxes. Machine learning means that even the data scientists sometimes can't explain what the underlying math is. So how do you create that trust? How do you reassure a provider or any other clinical user that the model prediction is appropriate for a specific patient? Some of that is showing the user that the patient demographics for the patient that's in front of them are aligned with the data set that was used to train the model. But the AI should be trusted. How do you convince the user to trust it? What information does the user need? So as an example, we are working with Mayo Clinic, Dr. John Halamka leading the initiative there to implement the concept of a nutrition label that will help a user know whether the content of the package, the black box, is appropriate for the situation.
That's a great idea. And a follow-up question to that, Jeremy, I'm going to put you a little bit on the hot seat because we have a great question in the Q&A. Do you feel for most of these models that we have sufficient amount of data to train the models properly, considering the complexity of the human body, right? And this is people's lives we're talking about. I think about that all the time. And then a second subset to that, really, because you brought this up a little bit, is the privacy concerns. You know, this is patient data that's going into feeding this, and we're matching that again with patients that are sitting in front of us, you know, and leveraging these models. So talk a little bit about that side of it too, the privacy concerns that might go along with it as well.
Sure. The good news is that with the digitization of health records, there are many sources for robust patient data. We think about the validity of AI models as being more related to the diversity of the data set, the diversity of records, and not necessarily the number of them. And being from Minnesota, we joke that our friends at Mayo Clinic, they have lots of data on Norwegians and other Scandinavians. Now, in truth, Mayo has accumulated over the past 40 or 50 years an extraordinary data set. But no, whether you're training a model on data using data from India or from the UK or from different regions of the US, you do need to understand that the diversity of data for validating the model that you've trained will be critical. On privacy concerns, there are certainly a number of different options that are available to model developers and to companies that have identifiable data and want to make that data available to model developers without compromising patient privacy. some of those, I won't name any particular companies, but some of those include what we call federated learning, where essentially a model gets deployed to a data source, or a model training package gets deployed to a data source, so that the data scientist isn't actually seeing the training data set. But the model is training on that, and the features then get brought back from multiple different federated data sources to ensure that diversity of source data. There's also an approach that others are using called synthetic data, where you essentially take an identifiable data set and you create a fake data set that has all of the same characteristics of that identifiable data set. So it is an important question, and there are many different approaches. I'm not sure we're increasing the number of approaches every 42 days, but there are a number of different approaches to address patient privacy needs.
Great. Thank you so much, Jeremy. I'm going to pose my next question to Arlen. You've been a part of AI initiatives for some time now, both as an academician as well as a practicing clinician. Talk to us a little bit about your experience about clinicians and health systems adopting AI solutions and how they approach further building on or improving existing solutions.
Thanks for the question. So I'll make a couple of points. One is that we're dealing with multiple individuals when it comes to the dissemination and implementation of any technology, but particularly when it comes to artificial intelligence. And by that, I mean, we're fundamentally trying to create a value proposition for many, many different customer segments in the sick care buying group. Those typically are people that are involved in operations, COOs, CEOs, chief nursing officers, those kinds of places. Second are clinicians. Third are finance and those kinds of folks. And the last are, last but not least, the IT people. So, and each one of those groups wants you to do it, wants AI and the people who create it to do a different job. So the trick is you have to create value propositions for each of those groups. And oftentimes their motives and their outcomes and their personas are very different. So it's really hard to solve the Rubik's Cube. The typical example, someone asked the question, what are the top of mind issues that healthcare executives want AI to solve? In this environment, as much as we would like to put quality and safety number one, for most clinicians, that's how they think. And congratulations to Eric and his team for doing that. The reality, though, is increase revenues, keep the heat, light, and electricity on these days, reduce costs, find people. I don't need to tell you how hard it is to find anybody to take care of patients and keep them working these days, eliminate waste, and probably use robotic process automation for repetitive tasks. And oh, by the way, reduce cyber attacks, because every ransomware totals $10 million per episode. So the reality of the situation is there are some very practical financial things that have to be done. 60% of hospitals are at risk of going under as we speak or have negative financial statements. So we can talk till we're blue in the face about quality, but the reality is we're really facing some significant financial issues. And that's why revenue cycle management percolates up to the top of the list. When you ask folks, what do you want AI to do? I want you to collect the money people owe us, and I want to be paid what we're owed. Help me fix that problem. No margin, no mission. The second, so that the other, and the final comment I would make is that when it comes to doctors, what do doctors want AI to do? I describe this as what I've called a quilt set, QWILTSET. We want you to increase the quality. We want you to not screw around with our workflow. We want you to make me money doing it. I want to be reimbursed for doing this. Legal, I don't want to get sued using something that I don't understand.
Sure.
And time, I want you to give me more time, not to see more patients. God knows we have too many patients we have to see. I want you to give me time to spend more time with the patients that I already have.
Absolutely.
And the set are social, emotional, and technical jobs to be done. I don't want to be embarrassed because I'm the last on the list to use this. I want it to satisfy all the emotional issues. And then are all the technical issues, which actually are fairly low on the list.
Sure. Thanks, Arlen.
Yeah, Arlen, if I may add, I agree with you on time. And it's not just time with more patients, it's time with more family time. I mean, one of the biggest complaints I hear with the EHR is, and I've been on that receiving end too, you finish your clinic and you spend another 2-3 hours after the clinic, after 5 p.m., dictating those notes or typing those notes in, trying to catch up. And, we all know as clinicians, that weight of not closing that note that day. And if you leave it to the next day, and God forbid, if your 72 hours is up, it's like an anchor around your neck. There's an emotional component to it. And they want to, just like everybody else, they want to be able to have quality time with their families and be able to recharge. And that's one of the reasons why we have such huge burnout rates, but both in nurses and physicians. And I agree with you. I think obviously we approach a lot of the AI projects from safety and quality, but over the last couple of months, we've geared towards more the clinical operations side. One of the things we're also looking at is, getting rid of unwarranted clinical variation. We have so much variation in the way we treat patients, and so much waste. We always hear anecdotally, a third of the dollars we spend in medicine is waste, has no effect on the clinical outcomes. And that's what we're targeting, trying to increase our savings, but also not affect the patient care. As a matter of fact, by reducing the unwarranted clinical variation, I do strongly believe you're going to improve the safety and quality, but also improve your finances tremendously. Thank you.
I agree with you. And I go back to, I would challenge anyone in our audience. I talk about the quadruple aim as opposed to the triple aim. But it really is about how do we improve the patient experience, because we know many patients in the US specifically don't have great experiences. How do we improve the quality? Because I think for us as healthcare providers, that really is one of the top things on the list. Maybe not health system CEOs, but reducing cost is part of that. And then I think again, the satisfaction of those that are working in healthcare, improving efficiency. Eric, you touched on many of those, reducing burnout. We have to be thinking about those things if we are gonna improve healthcare. Again, I'm speaking specifically here in the US, where we know that our quality outcomes are not great for the cost of the care that we deliver here. So I'm gonna move on to Erin. I am so excited again to hear more about this, but you have been part of pediatric mental health and this focus on eating disorders, clearly a ton of experience in that area. Tell us about how you think AI is going to be a game changer for this field specifically, and are there challenges that you really see that AI really can be used to help with?
Absolutely. I think, especially with the pandemic, the silver lining here is that we now really have a bigger focus just on how much mental health affects our population, adults and children. And even in urban areas with a plethora of resources, they still cannot even meet the demand. So we're looking at a national desert of mental health providers. And the societal cost, since we were talking about this balance of high quality care and what is the bottom line, is just astronomical. For eating disorders alone, it's a $64.7 billion waste annually of eating disorder patients who are not getting adequate care at multiple levels. So the first, and simplest way to kind of define where I think AI could be really helpful in mental health, and obviously a niche within the niche is the eating disorder population, is improving screening implementation, improving diagnostic precision, improving created individualized care, because not every human being is the same. Not every eating disorder is the same, even if an individual is meeting that DSM-5 criteria identically, and then certainly leading us to recovery. So when I think about this problem in our country. We know that 30 million people ages 5 and up to 80 have an eating disorder at some point in their lifetime. And only 10 to 20% of those patients actually ever have access to care. So we're talking about a huge oversight. So if we could incorporate AI into that initial screening period and helping clinicians, helping families, helping friends really give their loved ones and acquaintances more direct access by early identification, that would be huge. Everyone has a cell phone. Everyone is scrolling through social media, so not to get too much into the marketing play, because certainly I know nothing about marketing and AI. I do see a really important overlap there. So to get the word out there, to get these tools out there, and then once you have the patient, once you capture that patient, really using AI to help with that diagnostic precision and that treatment plan. We know what to measure. We know what psychiatric symptom burdens we are trying to qualify and quantify. We know what behaviors we're tracking as far as when they happen, how frequently it happened, was there any preceding experience or emotional state before it happened, what's the outcome of that behavior happening. If we had AI to collect that information, we could be using that in real time. I really like the concept of, having something in my left eye view to direct my decision making in the moment. I really liked that visual. It could just be incredibly transformative for how quickly we have earlier detection, earlier treatment, earlier recovery, especially for the child and adolescent patient population. And actually, I want to share some really almost terrifying figures, if I may. 42% of first and third graders want to be thinner. So before we get on the soapbox of what are we doing wrong in our society that leads a first and third grader to even have this concept, the scarier thing is 35% of normal dieters will progress to pathological dieting. And of those, 20 to 25% progress to partial or full syndrome eating disorders, meaning they have an actual pathology causing dysfunction in their life and interfering with their purpose, their values, their connection with those around them. So seeing just how enormous this problem is, having AI to close that gap, be part of the solution, be an aid to clinicians, I would say increase numbers wise how many points of access a patient can have to intervention really absolutely improves this outcome overall.
Well, I would add, just because I have some recent experience, unfortunately, this idea, I've just been, again, doing a lot of reading, and this idea that as pediatricians, like we should and can be looking at growth curves. I mean, we look at growth curves all day, every day, but to your point of kind of earlier diagnosis, really picking up some subtle changes in a patient's weight that we may think, oh, this patient's, getting a little bit healthier. They've gotten, I always ask the question, are you trying to lose weight or, that kind of thing. And we focus probably too much on BMI and, some of these things. It's this balance between how do you help kids be healthy and not put them in a place where, again, they are moving into more issues related to an eating disorder or disordered eating in general. So I hear what you're saying. The other place that I would say, and I'd love for you to comment on this, the idea of expected recovery weight and or, how to make those determinations. Sounds like there's a lot of data and literature on patients that have gone through programs, but there's not consensus on how to even determine some of those expected weights or goal weights, so to speak. And it would seem to me that you could leverage AI with all of the data that's out there to really help us determine, okay, what does lead to the best outcomes, et cetera. So if you want to comment on that, I'd love to hear your thoughts.
Certainly, I would imagine that ability to tap into the cloud of information would give the best outcome for that. But I like how Jeremy said at one point, math doesn't necessarily get you to the right care. And I love that you then said maybe we over rely on BMI. I could be on that soapbox for an entire day, really. You know, especially knowing that the BMI calculation was done by a mathematician to try to define the ideal European man. So think about the population that doesn't apply to, especially everyone under the age of 18. And really, I would say 25 because of how kids are developing and growing physically. So, you know, what do we do with growth curves? How do we understand them? I really appreciated your naming that you can pick up subtle changes. And also, not all weight loss is good. We as a society are really focused on weight loss as a measurement of health, but we actually have this diverse range of body sizes. You know, someone who is 50th percentile on the growth curve, that's not the average, that's just the middle. So it's not the mean and it's not the mode. This isn't a bell curve. It's just the middle. And we need that body diversity, just like we wouldn't expect everyone to have a size 6 shoe. So, you know, really being able to pick up on any slope change to growth and weight maintenance. No matter what line you're on, you could actually remove some of that bias if you had AI interpreting what's happening on a growth curve rather than relying on a clinician who may be behind in their understanding of how to best interpret a growth curve. So if someone was 98th percentile, had been their whole life long since infancy, and now they're dropping, there are providers out there who might say, oh, this is great. Look, your BMI is dropping now. This is fantastic for you. You're going to be healthier. When really that individual, even if their BMI isn't calculating to be below an 18, you know, or a 17, they actually could meet criteria for anorexia nervosa because of all the medical complications that come with drastic weight loss, no matter where you started from, whether you were considered overweight or not. So I like the idea of AI actually removing that human interference in the diagnoses and treatment connection for patients. Because we know that larger bodies are marginalized in this country and they deserve care just like anyone else.
Katie, if I could just, Katie, if I could pick up on something that Erin said a minute ago about taking advantage of AI algorithms, use quite simple inputs to identify, to predict potential diagnoses. We think that is very powerful. And we're doing some work with cliexa on this as it relates to predicting opioid misuse, where the inputs are relatively simple. And the goal is not to tell a provider what to prescribe, but to provide guidance to a clinician that this patient appears that she or he may be at risk of opioid misuse. So take that into account when thinking about your prescribing decisions. Similarly, we're working with another model developer that has deployed this model on 4 continents, including in the US, for predicting the likelihood of colon cancer and advanced adenomas. And using nothing more than a patient's age, sex at birth, and CBC blood count values, they have been able to identify that by running a group of patients, a cohort of patients' data through this model, they can prioritize patients and find 8 times the rate of colon cancer in the prioritized group compared to the general population. So that means you're focusing your scarce resources in the colonoscopy exam room. You're focusing your scarce resources on patients that need that screening the most and are at highest risk. And it's so simple to run that data, to acquire that data, to normalize that data, and then to run it through the model. So we're very excited, as Erin suggested, about opportunities to use existing data, retrospective data, and identify patients that merit the investment of resources.
Fantastic. Thank you for the addition. I actually want to move on to one other question from our audience, because I want to tag on to something that Erin said. And Eric, you can certainly start us off here. We talked a little bit, or touched a little bit on bias. And one of our audience members today said, how do you think AI can address gender, racial, and socioeconomic disparities within healthcare? Because again, some of that does relate to bias, where our disparities are coming from. But I just love that question because I think it is not only a topic that has risen to the top, I think, with the pandemic, but something that's very important for us to talk about. So Eric, I'll start with you on that.
Yeah, I think Jeremy at the beginning talked about Mayo Clinic and all Scandinavian descent. I think one of the things with AI is like a shiny brand new car, but unless you have the high octane fuel data, it won't go anywhere. And the data has to be large amounts of data. It's not just small amounts of data, and it has to be representative of the communities you serve. And so I think that's one of the ways you can get around it, is making sure that whatever models that people are training their AI modules on, AI platforms, the data is representative of the patients we treat. Now, there's also a data disparity around the world. Most of the AI modules, if you look at it right now, are trained in US, China, and somewhat in Israel, a little bit in Europe. So there's a positive. We have almost zero data coming in from Africa, very little data from Southeast Asia, except for China, and very little data from India and Middle East. So I think, when you look at it, we already have a data disparity in the universe, in our, world. But then when you look at the US, most of the data models are unfortunately trained on patients that are more in the affluent areas. One term I don't like as much is social determinants of health, because, the problem I have with social determinants of health is we're expecting most of these people to have the digital exhaust that some of us on the panel have. And unfortunately, some of these people, the underserved, don't have the same digital exhaust. They may not even have a credit card. They may not even own a car. They may not even have a home mortgage. So how do you expect to get their socioeconomic status or their social settings if they don't have the digital exhaust? And I think that's a big problem. I think we rely too much on that digital exhaust, but I think we have to find other ways. And I think the best way is to interview them when they come to the clinic, get these social determinants of health, rather than relying on some company to gather the digital information, which may paint you an inaccurate picture.
Yeah, and I would add to that every touch point, right? They don't necessarily have to come in for us to be able to be gathering that information. And I agree with you, an important piece. Eric, I'm going to keep you on the hot seat here. What are the regulations and compliances that ensure AI safety and efficacy? And we also had an audience member ask about the AI Bill of Rights. So can you touch on that a little bit as well?
Yeah, this is a really hot topic. Of course, Europe is a little bit ahead of us on patient data privacy. We've been discussing about this in different forums. I've discussed it with CMMI, with FDA. If we allow FDA to continue doing AI algorithms, medical device, software as medical device, it'll take us years to get through some of these approvals because they're so backlogged. My personal, and this is again a personal thought, is we should have the platforms be regulated, but not every single algorithm, because there's just not enough day and time to be able to do that. Now, I don't know how we're going to regulate the platforms, but my thought is in the next 4 or 5 years, we're going to have probably 5 or 6 really large AI healthcare platforms, from anywhere from revenue cycle management to back office stuff to clinical decision making to clinical operations to everything else in between. And I think those platforms should be the one that regulate the algorithms, not FDA. As far as who owns the data, that's a whole nother big question. I know Jeremy talked about federated learning. I'm in the camp that there will be a place for federated learning where the algorithm will travel from place to place without having the data to ever leave those secure bounds. But I don't think you can do everything with federated learning. I think there's still going to be need for this, congealed data where you can just really get the big data and run things through. So I think it's going to be a 50-50. I'm not sure the use of synthetic data, especially in clinical decision making, especially in that area. But I think we need to think about, how do patients not get taken advantage of and get their data monetized, but at the same time, we serve our patients by being able to bring all these amazing new discoveries in healthcare and science.
Well, I love your thoughts on changes that could happen. And I guess, you know, in my ignorance, are these things that we do see potentially coming down the pipe as far as changes in regulations and compliance? Or are these just things that we're going to wish for and hope that at some point in the future they'll happen?
Well, there's a lot of smoke about all of this in every corner I go. So when there's a lot of smoke, there's a fire somewhere. So I think
Sure.
I think these are all in the making. It will happen. I just don't know, you know, there's so many different groups working on these, you know, and I don't know which one's going to be the one that takes the mantle. What I don't want to see is government imposing on us how we should do it. We actually, as industry, should come up with the regulations as healthcare industry and be able to recommend to the government how we should do it. Because I've always found, you know, when you go to the government, the solution, the problem you bring, the solution they find is usually worse than the problem you initially bring to them.
Sure.
So I would like to have the industry really come up with all the experts and come up with a plan and then go to the government saying, this is what we'd like to do, this is what we propose, but we're probably at least another couple of years away from that.
All right, thank you. Arlen, we've talked a little bit, and I know you put a lot in chat around barriers and obstacles to widespread adoption. Do you think we'll get there someday? And if so, how might that be accomplished? And are there obstacles that we haven't talked about yet?
So the short answer is yes. I mean, already people have, we're seeing adoption and penetration mostly in, as I indicated in the chat, pattern recognition and convolutional neural network application, dermatology, pathology, retinal scanning. Yeah, not a day goes by when you don't see another vendor sort of hacking their wares to the CIO. So sure, I mean, these things are out there, they're working, they're gradually finding their way. I would remind the audience that the traditional wisdom is that a medical invention takes 17 years to become the standard of care.
Wow.
I don't think, now you could argue with the number, but we all know it takes a long time.
A long time.
I don't see it's going to be any different with artificial intelligence. I think another barrier that we may not have addressed is that doctors are from Venus and techies are from Mars. I mean, this is like arguing with your spouse. There's just a lack of communication. And the fact is that we all come from a different culture. So we have to overcome the barriers to technology, clinician interaction, and collaboration. And, oh, by the way, doctors don't play nice with each other. Doctors don't play nice with nurses. We need interprofessional collaboration and transdisciplinary collaboration. We need to eliminate the innovation silos at every single academic institution I've ever been part of. I mean, if any of you worked at a university, you don't know what the person across the hall is doing, let alone somebody in another building. So there's all kinds of issues with breaking down communication fundamentally and innovation silos. And I think fundamentally it comes down to how do we create the proper incentives for people to work together? And I listed some of them in the previous question, but you can't expect clinicians to keep doing this for free. I mean, the fact of the matter is, all of us have taken care of patients for free and will continue to do so. All of us have spent pajama time for free. All of us have talked to patients on the phone and been put on phone trees for prior authorization for free. You just can't do that anymore. I'm sorry, it just doesn't work. So the fundamental reimbursement problem, the fee-for-service versus value care problem, the business model is broken. And I think that because doctors don't care about the business of medicine, this problem is going to persist. Now, as you all know, I mean, this is like I'm crazy about this subject. And I'm trying to get people to understand that if you don't know how to practice the business of medicine, you have no business practicing medicine. So we need to rethink lots of business models, not the least of which is medical education and medical schools.
Sure. No, I appreciate everything you're saying. And we know that there's a trend toward more employed physicians. So that piece of it, I think, is something that comes into play. And the other thing that you talked about is education, right? I love hearing how many of our, well, we have providers here on the panel that are intimately involved in bringing AI to their institutions and or their practices, which is exciting, but getting more clinicians engaged in the process, I think, is another helpful way to reduce those barriers to adoption. And I love to hear that, but I think an educational piece needs to be there. I mean, we need to start talking about healthcare innovation, artificial intelligence, other things from the beginning of medical education and before. So I really agree.
Let me
with
just, I mean, Eric and I have been involved in several initiatives and to that very point, and I'm interested for him to chime in, but the bottom, I mean, what we're seeing is actually lots of cracks in the armor. And without going through chapter and verse, many of us, some on this panel, are involved with changing the medical curriculum to include data literacy at a minimum. Data literacy means just understanding data and what you're reading in an article. Is it applicable?
Absolutely.
Is it generalizable? That kind of stuff. So Eric, maybe you want to chime in on what's going on.
Yeah, I think the future of medical education is going to be physicians who are not excellent clinicians, but physicians who at a minimum understand data science. And the ones that are really going to lead are physicians who are dual data scientists and clinicians at the same time. Now we're seeing some of them come through, but it is a rarity. It's like a unicorn. You see a unicorn when you see a physician with a data science background. But the younger generation is kind of interested in this. You know, they're the millennial and Gen Z. You know, they are interested in more data, and they're really data adapt. They grew up with smartphones. They grew up with iPads. They like programming. So I think we're going to see that. But to Arlen's point, adoption in the medical schools and the medical education curriculum has been very, very slow. And I think somebody wrote it in there too. I sometimes say they're in academia because they still think of their glory days where they were at the top of the hill and nothing else happened. But those days are gone. I mean, I think the knowledge has become a lot more, revolutionized, a lot more liberal. You can find it a lot of different places. Katie, one point you made, I tend to a little bit disagree with you in a respectful way. The trend for employing physicians by healthcare systems probably reached its peak maybe just before the pandemic. And I see it now, the trend reversing. And part of that is because of the, operating losses we're suffering. And when you start making cuts and there's nothing else left to do, the other cuts you're starting to make is going to be trying to offload those medical groups into more, joint ventures. And you've seen that in primary care. There's so many different avenues in primary care, from One Medical to IORA to City Block, to any one of them. And I think
they're still employed in those systems, though.
They're employed, but they're not employed by the traditional, health provider organizations. And I think you're starting to see that differentiation, because up until the pandemic, it was usually you're in private employment, you're in private group, independent, or you're employed by a large provider healthcare organization. We're starting to see a big shift in that.
No, I agree with you, but and there are still quite a few that are in some sort of employed fashion. I'm not saying necessarily by a large healthcare system like the one that I came from originally. I think there are, unfortunately, a lot of people leaving healthcare altogether, but I love the fact that physicians specifically are thinking differently and thinking there's a better way to do this. And many of those are in smaller groups or systems that are branching out in more innovative ways to deliver care, which is very exciting.
Well, we also see a lot of PE going into it too.
Yes.
Private equity going in and trying to get the value within a couple of years. And this is not like a distressed, that's where I think things may go wrong, because healthcare is not like a distressed industry where you go in and lay off people and fix a couple of things and then sell it for 2 or 3 times the amount of price a couple of years later. So I think we're starting to see a lot of PE moving into the area as well. Yeah,
which, as you mentioned, may not be a good thing. Jeremy, I have a question for you. So in order for AI models to be constantly built and trained, what do you think the healthcare industry really needs to invest in? And a couple of follow-up questions to that from our audience really are around the adoption of AI auditing tools and what place they have, and talk a little bit also about open source solutions as it relates to those things as well.
Okay, so we spent some time already today talking about the importance of data diversity. And I made a bad joke about Minnesotans all being of Scandinavian origin. In fact, as Mehmet knows, the Mayo Clinic data set that cliexa used to do some model training is quite diverse because of Mayo's footprint in both the Southwest and the Southeast United States, as well as in the Midwest, and being an international referral center. So the data diversity is very important for model training. The other thing, though, that we're focusing quite a bit on is outcomes data. So in order to know whether your model is making accurate predictions, you need to be able to track longitudinally the outcomes from patients. How long, though, will it take to get reliable outcomes data that is relevant to what the model predicted? You can't expect that a day after the prediction has been made, that in all cases you will know whether the model's diagnostic prediction or treatment prediction was accurate. And in some cases, will the clinical intervention that was driven by the model prediction change the patient's outcome? And if that's the case, it means the prediction was useful. It doesn't mean the prediction was inaccurate. So does that mean you need a constant control set of clinical predictions? So these are all, to me, interesting questions that I don't have the answer to necessarily. Models that are continuously retrained using automation are called adaptive algorithms. The FDA has released some guidance on what their expectations are for adaptive algorithms. It's very new. There's going to be significant development on this in the coming decades. I think fundamentally, it still comes back to the basic question of how do you reassure the end user, in particular a provider that will be making treatment decisions, that the model's prediction is appropriate for a specific patient. And that leads back to the discussion we've had about transparency, about making the nutrition label available to the user so that they can look at the underlying training and validation population sets and make a decision as to whether this prediction is sort of applicable to my patient, quite applicable to my patient, somewhere in between.
Can you talk a little bit more about, so Eric talked about the kind of side-by-side testing of, here's the way we used to do things, and we're going to employ our new AI algorithm. We're going to run this side by side. What other ways or innovative ways have you seen to do that type of testing? Again, to demonstrate that not only is the algorithm accurate, but on the other side of that, we are looking at outcomes data, and we're able to see that we're predicting what we thought we were going to be predicting, and it's leading to higher quality care or better outcomes. Talk a little bit more about ways of doing that you have seen.
Yes, one of the things that we're going to be doing with some of our partners is very similar to what Eric discussed, and that is we will be deploying models behind the scenes, ingesting data, real-time data or nightly batch data, and making those predictions available to data scientists and to clinical managers to determine whether or not those predictions will be useful without necessarily subjecting immediately the clinical workflow to a redesign. And so one of the opportunities we have is, I completely agree with you, Katie, I agree with Eric, one of the opportunities we have is to do some silent analysis and then use the results of that silent analysis to make decisions. There are also academics and those that are working with academic consortia that are emphasizing the importance of ground truth outcomes. In other words, not a decision by an individual clinician about whether or not this is an appropriate diagnosis, but looking at lab results, looking at specific pathology results that can be trusted at a very high degree, where there is less qualitative judgment.
Great. Thank you. Thank you for adding more onto that, because I think it's an important discussion. Again, it goes back to the trust factor and making sure, you know, in the end, adoption, right? Do we have the data that shows that this works, that it indeed does what it says it's going to do, and it's going to help us in the end?
Katie?
Erin, I have a question for you. I want to talk a little bit more about mental health globally, because we know that this is a huge, huge issue. We know that AI relies on real and valid data, or what we hope is valid data. Talk about the importance of that data, and specifically in mental health, how pattern recognition would effectively help clinicians. I mean, again, it goes back to potentially, well, hopefully, earlier identification, earlier treatment, and better outcomes. But I'd love to hear your thoughts on that.
I think specifically it goes to what we've been talking about of how do you improve clinical outcomes by reducing the noise through the treatment process. So the repetitive tasks that all mental health providers are engaged in are really quite large. You know, when we're talking again about the psychological symptoms and eating disorder specifically, what behaviors are they doing? What maladaptive behaviors are they using as ways of improving intolerable emotional states, things like that? If we were able to build in AI to our treatment practices thus far, you know, right now it's pretty standard across the industry to use certain apps for data collection as the patient is living their lives, if they're not in front of the provider 24/7. You know, by being able to analyze that data more in real time rather than with a delay like we normally experience, because at the end of the day, we're one human being if we're the provider, and maybe we have 20 patients on this app to sit there and go through every single account and then quantify, qualify the data, that actually delays treatment adjustments. So if we had AI to actually calculate everything that's coming into a system to then again be that, I'm not going to stop with this, Eric, on that, you know, right view guiding clinical practices, we can actually improve the efficiency of our time when we're meeting with the patients in our sessions. You know, certainly I feel like I'm in that generation that is, even though I'm a millennial, I'm an old millennial. So I do remember when AOL first came around. I didn't grow up having the internet as a readily, you know, available tool in my life. But it's interesting, you know, data collection historically was always more of a posthumous, if you will, approach to treatment. What can we look at after the fact and then use that data to name and change what we do moving forward? But again, we are living in this age where everything is dynamic and changing so rapidly. We cannot rely on that same model anymore in order to really provide the most effective care. So not only do I see AI, again, really being essential to the quality of care in the moment, but we will need to use it in order to guide ongoing decision-making and really ensure the efficacy of treatment longitudinally. And I think we might have to rely on that old model for a period of time. Of course, you know, I was thinking about the concept of how do you have the time available to demonstrate accurately and reliably that what you predicted is actually the outcome. You know, how do you measure that? What is the time frame necessary? What is the N if we're getting really into data analytics there? But I think by pulling all of this in together, I can imagine, and again, I'm not a biotech human. I understand that maybe to survive as a successful physician moving forward, I'm going to need to download more of that training. Maybe I'll take another board I really think that there could be a change in how we see data and how we use data and not have that lag.
Yeah, can you talk just a little bit, only because I have interfaced with some, I would say, interesting ideas and solutions, innovations out there that are looking at data mining from things like social media accounts to get an idea of their mental health, and again, I realize there's privacy concerns, so I'm going to take that out of it, but even the natural language processing and how, if I'm talking on the phone or I am having a conversation with my friend, picking up on my mood and some of the cues from that. And is that information really that we could leverage, again, for this earlier diagnosis and treatment, especially as it relates to mental health? Can you talk about that a little bit?
Yeah, I'm having a hard time removing my own initial cringe of imagining someone listening to our phone calls. It already feels like my Echo, Alexa is hearing things all the time.
How about an audio journal? It's my audio journal that I'm sending
audio
to
journal
you about how I'm doing.
Yeah, I definitely think there are keywords that we could absolutely, could imagine, teach a machine to pick up on. And especially looking at the frequency in a period of time that it's happening. If someone is really reporting hypersomnia or inability to sleep, and it's ongoing for days and days, that would be predictive of they're going to have some psychological outcomes from that are probably dysfunctional. And can we pick that up earlier? Definitely, again, I'm not trying to put just my eating disorder pathology lens on everything, but when people are wondering, lose weight fast, that alone is pathological. And yes, that's culturally influenced, but it would be important to follow that human to see, are they going to do it within reason, or are they actually going to push themselves into a starvation state and now have that dysfunction that comes from low brain activity as far as in the frontal lobe and whatnot. I think there would be ways of picking up and having some predictive validity on who is going down a destructive path. And it would be from certain buzzwords, certain behaviors, certain interests.
What I'm buying at the grocery store.
Yeah, if you're suddenly buying everything fat-free, sugar-free, a full dinner, you're searching for dinners that are 500 calories and less. I mean, none of this is actually how we're supposed to utilize food as fuel and food as something we enjoy as a human species. So I do think there would be lots of cool ways of pulling that in. And you're right, the biggest barrier is that privacy component. It's hard to get around.
Yeah, no, thank you for going down that little rabbit hole with me, because there are definitely, I know there are some solutions that are being employed really to help in those areas. Again, following all privacy restrictions out there. So I gave probably some bad examples, but thank you for answering that question for me. I would love to hear, again, a little bit from Eric on, we've talked about the predictive and diagnostic features. When you think about, okay, what's being done currently in that realm, what are some of the ways you could see that being expanded in the future? Talk a little bit about that.
Yeah, I'm glad you asked me about that, Katie. I was itching to answer that question. So a lot of people ask me, where do you see AI making the biggest effect? Which specialty? And of course, everybody expects me to say, oh, vascular neurosurgery by all means. And absolutely not. I think the biggest area it's going to make the biggest difference is going to be primary care. And you don't hear patients, well, I mean, just think about it. You hear people saying, I'm going to get a heart transplant. I'm going to go to Cleveland Clinic, right? If you have really hard cancer, difficult cancer, you go to MD Anderson. But how many people say, I'm going to go to Johns Hopkins to get my primary care, or I'm going to go to Mayo Clinic to get my primary care done today? Primary care is very different because, first of all, there's all this data that the primary care physician has accumulated on their patients. And it's both structured data, and I'll get to that in a minute, but also unstructured data in the clinical notes. And right now, if you go to rural Elkin, North Carolina, which is in my backyard, a primary care physician, I can guarantee you, does the same exam or does the same lab test for an annual if you go to Mayo Clinic. It's the same thing. There's no difference. But over the next couple of years, you're going to start seeing that differentiation where AI is going to start coming into primary care. And again, going back, when the primary care physician walks into the clinic, before he or she walks in, there's going to be a cheat sheet saying that here are the 3 trends that are worrisome. Going back to, and we look for expensive stuff. People were asking me about Meta's new lens, $1,500 lens. How can we use that in medical care? I'm like, well, before we jump into this, why don't we use the stuff that we already order and we don't use a lot? One example.
Sure.
Comprehensive metabolic profile.
Sure.
How many of us physicians have always looked at those 20 values when we get those values in our clinic? I can tell you nobody, 99.9% of the physicians probably don't look at every 20 values. And plus, you go back and look at the trends on those comprehensive metabolic profiles over the years for the patient. For each one of those sodium, chloride, potassium, GFR, do you look at all those? No. That's a $20 test. We leave so much structured data on the table. So going back to Jeremy's point, I think we can predict colon cancer, especially on people who have insidious loss of blood. We know that. They may start at high normal red blood cells, and it may go to low normal. And if you look at one point in time, it may not tell you the full picture, but if you look at it on a trend, it's going to tell you this patient is starting to lose blood. They've never done this before. So, and again, x-rays are another way that they're going to be able to do. And then unstructured data, there's a gold mine of clinical notes. Again, I go back to how many times when we get a new patient, we have to scramble to trying to get the cliff notes and hoping that we can capture in our vision as we're opening note to note and lab to lab that patient's condition that relates to us and our practice. So I can tell you next 2 years, it's probably not that far off. We're going to start seeing a huge differentiation in primary care groups that adopt AI and start using these predictive analytics, the pattern recognition. And again, the physician is going to, I always said, I've been saying this for 5 years, physicians who use AI are going to put physicians who resist AI out of business. There's just no way.
I love it.
And
I'm an early adopter. I'm ready.
You're good. You got a job for a long time. The reason is physicians who adopt AI are going to be much more effective in diagnosing. They're going to have more time to spend with the patients, and the patient satisfaction is going to be up. Now, I also saw one other question, the litigation part of this, right? Sure. I remember, and Arlen's old enough like me, I remember when I first started giving IV TPA, the clot busting drug, the physicians used to argue, well, we're going to get sued if there's a brain bleed, which was less than a 6% chance. Within 5 years, that flipped. So if you didn't give that clot busting drug, you became liable for that patient. I think it's going to come to a point where if there's a life-saving algorithm and it would have made a difference in the patient's life and you didn't use it, you're going to be liable for it. And so it is going to flip. But to me, I'm a half full guy. I'm actually excited about what is in for healthcare for the future, even though we have depressing numbers about not enough millennials, not enough Gen Zers to go to the workforce. We can talk about that for a whole nother 2 hours. But I think we're going to have a chance to reimagine, re-automate, re-engineer the workforce and make people fall in love with medicine, especially nurses, for what they do.
Yeah, hopefully all healthcare providers, because I think we need more people coming into it. It's a great profession. Taking care of patients is an amazing opportunity. There are many other opportunities in healthcare that are not directly patient facing. So we need, people doing everything, and it's a great place to be. But I know that we can do better in the future. And I think AI is one key to making that happen. I'm going to take a couple of in our last minutes here, a couple of our questions from the audience here. And I know there's been some questions being answered in the chat as well. But Arlen, I'm going to pose this to you. What changes do you think need to be made at the administrative level, high-level administration level, and steps that healthcare systems can take to really smoothly change behavior and adopt AI and increase the rate of integration?
So my view on this question is that AI digital transformation is a 3-level process. Number one, we need to change the physician clinical mindset to an entrepreneurial mindset. And each one of these statements comes with a lot of baggage. So if you want me to get deeper in the weeds, I would. So phase one is the present mindset of physicians is not conducive to digital transformation. Number two, the so the second level is organizational innovation readiness, just writ large. Most organizations, as I don't need to tell this audience, is highly resistant to change. And the headline is, sick care is about a culture of conformity, not a culture of creativity. So number two, the organizational culture. Number one, the individual physician mindset has to change. Number two, the organizational culture and mindset, readiness, innovation mindset has to change.
Absolutely.
Number three, once you have done that, then you can begin to talk about AI and digital transformation. If you don't do that, you wind up with what we have now is the artificial data tail wagging the workflow dog. In other words, we're going to take everything you are doing now and we're going to digitize it, when in fact, everything we are doing now is dysfunctional. So if you don't fix the workflow, and if you don't fix sick care into healthcare, and if you don't fix the business model, all you are doing is garbage in, garbage out. And you're just making it easier to do the wrong thing.
Great points, Arlen. I'm going to let those be your last points. I'm going to check in with all of our other panelists for one last comment. Jeremy, I'll start with you.
Thanks, Katie. I just wanted to underscore something that Eric said a few minutes ago about the opportunity for primary care. I'll give one more example. There are 100 million electrocardiograms performed in the United States every year, EKG or ECG, depending on what country you're from, I guess. And JAMA did a review in the last year or two, found that even among trained clinicians, a third of those were misread.
Wow.
Right? So there are very well-established, simple models that will identify AFib and low ejection fraction from an EKG. So you take that EKG, you take 100 million EKGs and you run them through those models, and you identify patients who look like they have AFib or look like they have low ejection fraction, and you get them into proper treatment earlier, while it is still relatively inexpensive and while you can preserve their quality of life. That's something that can be done in a primary care setting. It doesn't require the patient to be so sick that they're being treated by an EP. So great opportunity. That's just another great opportunity. And again, thanks everybody. I really appreciated the conversation.
Thank you, Jeremy. Erin, on to you.
I've really enjoyed being on this panel, especially hearing from people who've been on the front lines of this new data mission to bring better data analysis to healthcare and improve our practices. I mean, certainly one thing that I'm really excited about in having a brand new company, I mean, we're in the nascent of our company's creation, and we are wanting to, if anything, I'm validated by what you said, Arlen. We are really trying to incorporate that data gathering and analysis now, in the moment, and moving forward, not just waiting until after the fact, after patients have already been working with us or have completed care with us, and really wanting to remain committed to thorough data collection, inclusion of data, foci where it needs to be in that foundational fabric of our clinical structure and workflow, which is why tech partners are so important. And I'm looking forward to development as we continue to incorporate these two sides, and instead of having a dysfunctional partner, one's from Mars, one's from Venus, we can actually bring the two together and create a very functional marriage.
Thank you, Erin. And Eric, some last thoughts?
Yeah, I just want to tell you my appreciation for both Mehmet and you for hosting this. This has been incredible, mind sharing for me. And the future of healthcare is really bright. And I truly mean that. I wouldn't be here talking to you about that. I think we need to really accelerate our AI initiatives and go after things that are really going to make meaningful changes in our patients' outcomes. Thank you so much.
Yes, and a last thanks from me, our panelists. Thank you, thank you, thank you. You guys did an amazing job. So wonderful to hear your expertise and your insights. I learned a lot, so thank you for being here. Big thanks to Mehmet and Cliexa and Ilul for helping put all of this together. We appreciate it. And thanks to all of our attendees for being here. I agree with you, Eric. I think the future is bright. I think AI can be a game changer, which is really exciting. And I can't wait for our next webinar. I'm not sure what it's going to be on, but I'm going to have Mehmet start thinking about it now. So thanks everyone for being here today, and we'll see you again soon.